We will come with yet another case discussion. We had a case discussion on metabolism where we saw that enzyme induction, enzyme inhibition, CYP enzymes were very important. Likewise, as liver is very important organ, so also kidneys. So we have to see whether kidney has got normal function or not. As such, physiologically, the kidney function starts decreasing, not deteriorating, decreasing by 5% after 55 years of age. This is physiology. Okay, so even when you calculate creatinine clearance or whatsoever, or whenever you give drugs, the drug cannot get excreted by these elderly people. So you have to adjust the dose. So you have to know which are the drugs which cause so much of toxicities, even otherwise. And one of them is the most important, that is lithium, which is used mainly in bipolar disorder. But we will see later on, instead of lithium, what else can be used and what are the problems which are caused, especially with renals. And so we will deal in little more in detail about it, so that when there is a sole problem, what is the contribution of this to the kidneys, or kidneys contribution to lithium, and also when there is comorbidities, what is the problem what we meet, or are we using such a drugs where there is no problem at all, even if the person presents with 2 or 3 diagnoses. As usual, follow this one. A 40-year-old man, please note down the important points. We will come to that later in a tabular form. But here, you just follow this so that half of the problem should be solved by just reading the problem, or in front of your eyes, this disorder should be there so that you can really make out the difference. A 40-year-old man presents to the hospital complaining of vomiting, describes a 2-day history of abdominal pain with vomiting and diarrhea, denies experiencing fever, cough, and urinary tract symptoms, had no unwell contacts and not traveled. Past medical history included bipolar affective disorder. So please be aware, for which he took a total of 1200 milligrams lithium in daily in divided doses. And the dose has recently been increased by community mental health team due to recurrent episodes of mania. So he's a 40-year-old person, no other problems, but these are they have increased the dose, possibly because he has come with some of the other problems which can be either bipolar affective disorder 1 or even 2. Okay, so what were the parameters we looked after? Most of them were normal except for resting tremors affecting both the hands. Resting tremor affecting both the hands. Where do you find fine tremors? Fine tremors is found with beta 2 agonists, that is salbutamol, salmeterol, formoterol, bombetrol. Okay, so these are the things what you should think the moment you see any of these findings in any of the persons. Next, regarding the investigations, I think almost all of them are normal. Uh, we have to see here about creatinine, which is quite normal, and potassium more so, which is little on the lower side comparatively, and sodium is also quite normal. Now, what is the most likely cause of the patient's symptoms, and how will you treat this patient? We have already told that they are bipolar disorders. So, in bipolar disorders, the drugs used as of today are mainly these. First is lithium. We will see later why we are not using so. The best alternative is sodium valproate, but contraindicated in reproductive age group in females because of teratogenicity and spina bifida. We do have other adverse effects like pancreatitis, hepatitis, alopecia, serum transaminase being increasing, and it is an enzyme inhibitor more so. So these are the several problems, but still it's a good drug. The basic one being an anti-epileptic, but we do have 2 or 3 other uses of sodium valproate. One amongst them being bipolar disorder. Next, lamotrigine, again a newer anti-epileptic drug where it has got a different mechanism of action, and so we do not have the central side effects as much as we see with others. So this is also one of the drugs of choice in the maintenance phase, not in the acute phase. Carbamazepine, sorry, I have written carbamazepine again. It is oxcarbamazepine or oxcarbamazepine, where we see with oxcarbamazepine we do have little bit of less problems as carbamazepine. We will see to that little later. Now, here the person is suffering from bipolar disorder. So, what do you mean by bipolar disorder? The patient can swing between mania and depression, or he can have same at both the given times, or he can be swinging one more than the other or one less than the other. So, most often it will be a combination. So, then we say it as bipolar disorder. The first drug will be lithium, but nowadays sodium valproate. If it is a manic episode, then we use antipsychotic drugs, that too atypical antipsychotics like clozapine, olanzapine, okay, risperidone, whitepine, okay. Then we have aripiprazole. So amongst them, we prefer to choose olanzapine and aripiprazole very commonly. But if it is depression, we commonly use quetiapine and lurasidone. Or at the same time, we can combine again with lamotrigine. If they are resistant to this, then we commonly use olanzapine, though the weight is the problem, especially in females, PCOD, etc. But still we prefer olanzapine because we can give by intraparenteral route of administration. That's the reason why we have chosen olanzapine amongst all the other antipsychotics. If there is depression, you have to choose most of the times lurasidone or other SSRIs along with the above one of the above four mentioned drugs. The most important one after choosing these drugs, you have to see that you T3, T4, TSH is measured. Why? Because this hypothyroidism also exhibits mood swings. So because of this, you have to find out the levels of T3, T4, TSH apart from CBC and other things, where I think this in this case it was not done also. See here, there is no this one except for lithium level being increased. Nothing else we see, but they should have done T3, T4 is TSH because mood swings very rapidly with hypothyroidism. So you have to stabilize hypothyroidism in addition to treating bipolar disorders. And nowadays we use this S-ketamine to reduce the suicidal ideation. And sometimes on a long term, we do use bupropion also. These are the last drugs what we use. So the main drugs being lithium, sodium valproate, lamotrigine, carbamazepine, oxcarbamazepine, along with an antipsychotic or the lurasidone, as the case may be, of mania or depression respectively. Okay, so now let us concentrate on lithium, because still if you are in a place where nothing is there, you have to administer lithium. There is no other go. So we'll just see a few important things about lithium. That is, see, these are the lithium indication is bipolar 1 disorder where there is acute maniac or mixed episodes as well as maintenance as an adjunct in major depressive disorders, vascular headaches and neutropenia. The FDA approved one is mainly bipolar disorder. The mechanism of action is mainly it affects the sodium transport. So sodium is very important. It is in exchange lithium in exchange with sodium. So wherever there is hyponatremia, then there is a big problem. Impacts catecholamines, mainly noradrenaline, and also serotonin metabolism. So you have to be careful when we add SSRIs, and affects second messenger systems and promotes neurogenesis. So the main action is centrally mediated, and it acts only on the affected neurons where it converts the IP3 inositol triphosphate, and hence it acts on those neurons to stabilize the mood in the affected person only, in the affected neurons only. That is the beauty. But other problems are there. So this beauty cannot be appreciated, though this has very nice mechanism of action. Now, coming to absorption, it has got very rapid absorption, very rapid absorption. So to say 100% bioavailability. So you have several formulations. It can be taken as sustained release, tablets, capsules, everything. But you have to be very careful because it can get absorbed 100% and 100% bioavailability is there, which is quite a fearing one when it is 100% bioavailability. Okay, then distribution, it is not at all protein bound. So when it is not protein bound, there are free drug and it is ready to act anywhere and everywhere. But one main concern we can have, one positive concern what we have is, whenever the drug is in the plasma, with every circulation, it is undergoing metabolism. It is undergoing metabolism. So for that reason, we can be little bit quite safe, but at the same time, free drug is more because absorption is also complete. So because of that, we have to be careful whenever free drug is there in the blood. Metabolism, again, when no metabolism occurs and and it is excreted unchanged in urine. So what's the important point? So renal function should be apt. So you have to have creatinine levels, more so creatinine as well as sodium levels, because it gets exchange with sodium, because these two are very important. Without these, you should not start on lithium. The elimination is primarily renal and it is reabsorbed in proximal tubules, again a problem, and the half-life being 18 to 36 hours. So you have to decide how many times a day you will be administering it. As I told you, because it has got 100% bioavailability, we have got several dosage forms: tablets, capsules, liquid, as well as sustained release, where we initially give 600 and the maintenance dose is 300 to 600, where this dose normally we reach the target serum level 0.8 to 1.2. I told you in the last class also, see, everybody can't be affording TDM. So the clinical way of doing this TDM is giving a drug holiday. Or if you feel that it has got very narrow margin of safety and TDM has to be done, you have got better drugs nowadays, so you can definitely choose them rather than choosing this and introducing one more disease because of prescription, so-called prescription cascade. So in case of renal impairment, we have to adjust the dose if the creatinine clearance is below 30 ml, which is quite common in any of the drug usage, not only with lithium, with everything. In pregnancy, we have got cardiac malformations, especially tetralogy of Pallet like phenomenon. So should never use it at all. We have got better drugs also nowadays, so don't use it at all. Breastfeeding, again, avoid and use better drugs. Pediatrics not below 7 years also. And in older adults, you should not use with AC inhibitors or diuretics. And if at all you use, you have to use with very low doses, which I'll be commenting it on in the pearls section. Lastly, we have got the adverse effects, where you have to be very careful. Adverse effects. You have to be very careful about the adverse effects, especially cardiac, bradycardia, then T wave changes occur. So if there is any ST depression and all, you have to be quite careful. And CNS, all CNS drugs are known to cause confusion, sleep, tremors, hyperreflexia, etc. Renal, it can cause nephrogenic diabetes. Diabetic insipidus will take it in the some other class, but basically we have got two types. One is pituitary and one is nephrogenic. We have to differentiate between the two because the treatment is quite different. So here we have got nephrogenic diabetic insipidus, and the gastrointestinal are very common, that is diarrhea and nausea. So you have to be careful that it should be administered along with food or just after food. And endocrines, both you have to look upon parathyroid as well as thyroid, because we have to monitor T3, T4, TSH with hypo, and in hypercalcemia with parathyroidism, where we usually miss, and to diagnose only we might take at least about 2 to 3 months, because we forget parathyroidism being an endocrine organ. Next, we have the same continuation. Here we have mainly this hematological effects, leukocytosis and aplastic, and it can go to aplastic anemia also if it is not monitored properly. And obviously, most of these drugs do have weight gain, especially more so in women and in adolescent group and reproductive group. They may land up even in PCOD also. The drug interactions are mainly thiazide diuretics. What is the problem? In thiazide diuretics, we cause hypokalemia, and these drugs should be changed if at all we are using it for hypertension. Why? Because the electrolyte imbalance, because all diuretics are known to cause electrolyte imbalance, mainly hyponatremia, hypokalemia, hypocholeremia. These are the three main problems which we see, and thiazides are no exceptions for that. So for that reason, instead of if you can't change lithium, you have to change thiazide diuretics. But I feel preferably change lithium we do, because we do have other drugs, and thiazide does act more so, not only decreasing the volume but also it acts as a vasodilator. So because of that advantage, you have to use it as an antihypertensive drug, and you can change lithium because these will increase the lithium levels. Obviously, NSAIDs, which will act on prostaglandins, on the kidneys, and so it will normally PGs cause vasodilatation. NSAIDs block that PGs, vasoconstriction, decreased GFR. All these are the problems which can delay the excretion of lithium and increase the lithium levels. Renin-angiotensin system antagonist, that is RAS, renin inhibitor, aliskiren, then angiotensin inhibitors, that is AC inhibitors, as well as ARBs, and also aldosterone antagonist, mainly renin angiotensin, that is three drugs. One is renin inhibitor, aliskiren, and AC inhibitors and ARBs. These should be monitored again for the same reasons as thiazides. Metronidazole, both have metallic taste, and also metronidazole will increase lithium levels at the level of metabolism. Serotonin syndrome risk is very, very important. What you should see, co-administration with serotonic agents. So serotonin syndrome can be known, especially if the patient not only he's on lithium but also an SSRI. Whenever there is a bipolar disorder with depression predominant, in such cases you see these things also. Lastly, neurological adverse reactions with antipsychotics can lead on to extrapyramidal symptoms. Which are the drugs which cause extrapyramidal symptoms in antipsychotics? The typical ones, that is chlorpromazine, haloperidol, and in atypical antipsychotics, it is mainly risperidone which causes extrapyramidal symptoms. And neuroleptic malignant syndrome is the most common cause, most commonly caused by chlorpromazine, which we hardly use it when other things does not work. When it is cost effective only, we use such drugs. Otherwise, we are very fond of atypical antipsychotics, where we do not need much of these monitoring, and good quality of life can be maintained with all these atypical antipsychotics. So with these adverse effects and drug interactions, the contraindications will be as usual: hypersensitivity, excipients. Especially, you should register in your brain several severe renal impairment where creatinine clearance is below 30 ml, cardiovascular disease, especially in children, or pregnancy where there's risk of arrhythmias, unmasking Brugada syndrome. So this is very important. So should never be used. Contraindicated absolutely in pregnancy. So next, because of these things, we have box warnings. What do you mean by box warning? Box warning is nothing but when we take the tablets, in a box, in that one slip will be there, and there they would have written in the package insert, they would have written box warning. They would have written completely this: toxicity occurs even at near therapeutic levels. So if you change from 0.2 to zero point 0.3 or 200 to 220 milligrams, then there may be toxicity in that person, which will increase the therapeutic levels, and it will facilitate, and the measurements are very essential. So these are the ones what is written in the package insert, and especially this box warning will be written in big bold letters, so that it should be only by a prescription drug, and even the pharmacy has the responsibility to see that it is given under an doctor psychiatric supervision. And also, if there is a refilling of prescription by general practitioner, they should know that these do cause these problems, and hence they should be able to say what is box warning, and also caution the patient, though old patient is better than a new doctor. So you be careful with hyponatremia, any volume depletion. Hyponatremia, volume depletion, especially sodium depletion and also volume depletion, then especially during infections and dehydration. Then CKD, because the creatinine clearance will be very less. Thyroid issues, mainly hypothyroidism, though we have certain cases of hyper, mainly hypothyroidism. Hypercalcemia, where we see hypercalcemia, where we should still check for whenever we see for serum hypercalcemia like electrolyte imbalance, we will check for all five, no, sodium, potassium, chloride, magnesium and calcium. So in that cases, even if it is the upper borderline, so please be aware of that calcium, why it is high, because it's always absorbed in the pathway, in the paracellular pathway, in the loop of Henle, along with sodium, potassium and chloride. If there is problem with sodium, potassium and chloride, there will be problem with calcium as well as potassium also. But if it is the reverse way, then you have to be really aware why this hypercalcemia is being caused. And so you have to look for hyperparathyroidism and correct it immediately, so that we are not going to land up in any severe problem with this bipolar disorder. Then pre-treatment, we have to check for kidney and thyroid function test and also ECG. Kidney, creatinine clearance, okay, and sodium. Thyroid, T3, T4, TSH. Then ECG, T wave changes and hence arrhythmias, especially in patient above 50 years. And also weight is also quite important, because all CNS drugs are known to cause weight gain, because the patient will be in a castle and he will not have any other work, and persons surrounding also will show a great mercy. So the problem with all these CNS problems is eating, sleeping. So weight gain might be very important, and so you have to look upon and monitor these things very regularly. So you have to be very, very careful with these things. Next, toxicity. Toxicity occurs beyond 2 milliequivalents per ml. We have to monitor. We have to take the serum and then look into it. The symptoms can be nephritis and all is too high, mainly by ECG arrhythmias, hypertension, BP, by ECG T wave changes, and pseudotumoral cerebri and seizures. Obviously, the patient will be directly in ICU. So, how will you manage it? The management is mainly by hydration. The first one is hydration. Why? Because why? Because it exchanges with sodium. It exchanges with sodium and hence promotes excretion. That's why hydration is very, very important. Next, these are the higher levels. Extracorporeal treatment. The indications include coma, myoclonus, cardiopulmonary collapse, and whenever serum lithium has gone beyond the limits, and we also see some sort of kidney dysfunction, and ultimately when do we suggest hemodialysis? And when hemodialysis is not warranted? See, hemodialysis phenomenon you should attribute to a drug where it is confined to plasma, not going and settling in other organs. Like, for example, heparin, lithium, they all are confined to plasma, so you can remove it directly. If not, on the contrary, you have chloroquine, which is accumulated in the liver, digoxin in the muscles, chloroquine also in retina. Okay, so some of these are the examples where they go and get lodged, or even intravenous thiopental sodium, where it gets accumulated in the fat. So there you cannot extract from those organs. You have to sit and wait how they will be excreted, metabolized by kidney, metabolized by liver, and excreted by kidneys. But if the drugs are confined to plasma only, hemodialysis can be easily done, because they will have low volume of distribution and they will have high molecular weight, so that they cannot get transferred to the other organs. So in such cases, hemodialysis is the most useful one compared to other levels of treatments. And the other thing, the most common thing the patient comes with is with the tremors. So you have to manage that. You cannot leave it like that, because patient's symptom is more important than our findings. Our findings comes later. but patient comes with certain symptoms, there you have to manage with propranolol because it is always in the muscles, and in the muscles you have beta 2 receptors. Because of that, you have to antagonize, and low dose propranolol are known to have these blockers, so it can reduce tremors. These are the this is one of the non-cardiac indication of propranolol, because nowadays we never use for cardiac conditions except for cardiomyopathy. All the others have their own choices of beta blockers, whereas with non-cardiac conditions we do propranolol stands a good hold even today, like in hyperthyroidism, in anxiety, tremor. Okay, and then this one in glaucoma, mainly timolol, and in pheochromocytoma, we were using along with with phenoxybenzamide. Now we have got a beta blocker which has got both activities, alpha and beta, that is labetalol. So propranolol has got, and also we use it in prophylaxis of migraine. Though many of them use flunarizine, propranolol cannot outbeat any drug. If at all the patient compliance is good, even the best of the migraines can be resolved permanently with propranolol, provided the patient takes it very, very properly, listens to you, and you can be behind them, because today WhatsApp is there and you can message, you can contact and do all those things. So if you do like that, there will be patient retainability. So you have to retain more than just treating for one day and sending them off. So you have to retain the patients. So if you do it, put them on propranolol properly, and then taper the dose so that there is no withdrawal symptoms. There is nothing like propranolol for resolving migraine. So also in these tremors, if you use it at lower doses, definitely this can be solved without any problems. Next, I have just quoted some of these because if at all we cannot monitor properly, or if the caretaker does not give properly, these phenomenons can be encountered, and so we will have these problems. Well, what happens if there is excessive intake, or what happens if there is impaired excretion when no monitoring is there, or whenever we have chronic therapy, what can happen? Patient do not come, compliance is not good. What happens, and what is its effect on toxicokinetics? So these are few of the very important points what you have to remember. If there is excessive intake, suppose the patient takes by himself, he is educated, he wants to know by himself, so he says he can manage. In that case, they can land up in suicidal, or it can be even accidental. Excessive intake can be for both of them. So here, and also it can be acute, or it can be acute on chronic overdose. The patient will be taking, suddenly he takes 4 or 5 tablets at once. So these are the problems. So how to solve this? This is by dose modification on chronic administration. So if you tell them to come every 15 days, or if you give them the phone number, they definitely will agree and stay upon to that method. But we are also not bothered, they are also not bothered, and they are more worried about the finance. So what they'll say, they keep on taking by themselves, and that can cause the accumulation of these drugs, which can lead to overdose and toxicities. But on the other hand, the patient is taking the said dose. There is no problem. In between, he forgets 1 or 2 days. So it can work like a drug holiday. So the serum levels are maintained, but there is impaired excretion. Impaired excretion can be due to so many problems. The first being the age. So you have to adjust the dose according to age. So not only you should remember all those, you have to remember age also. And these are, and elderly people do not drink water. They, and most of the times, whenever the patient is hypertension, will say don't take salt, diabetes, don't take sugar, don't take that, don't take this, and eat tablets as meals. All these will be the problem. So there will be sodium impairment as well as dehydration also, and these can lead on to impaired excretion. Not only that, they can have other nephrogenic problems, including nephritis and chronic kidney disease, etc., etc., and also which can also lead on to decreased GFR. So the first problem will be sodium or volume depletion. Next, enhancing lithium reabsorption. We saw in that pharmacokinetics slide that it can get reabsorbed in the proximal convoluted tubule. So if it gets absorbed, again lithium concentration increases, which can lead on to toxicity because of impaired excretion, and more so it can decrease GFR also, again like somewhere something like chronic kidney disease due to diabetes, hypertension, etc. Or when we are using drugs like aminoglycosides, diuretics, all these are excreted by the kidney. So you have to be careful but for the drugs which are excreted by the kidney, and also drugs which cause nephrotoxicity. So these are the problems which are met. So you have to know these things. You have to keep on asking drug history, drug history, drug history. Only then you can make out where the problem is. Next, in patients with chronic therapy, they can precipitate nephrogenic diabetic insipidus, where there is diminished urinary concentrating capacity, and the treatment in diabetic insipidus. Thiazides are the drugs of choice. Just now we told thiazides we should not use, but here we are saying treatment thiazide. Here it acts paradoxically, both at the level of the DCT as well as collecting duct. It acts and sees to it that the lithium is excreted in a better way, and so we use these thiazides in nephrogenic diabetic insipidus. Also, NSAIDs, which can cause prostaglandin vasodilatation, is blocked, so vasoconstriction. So, little decreased lithium enters into the glomerular filtration as well as PCT, where the reabsorption also can be minimum, and also have little bit of low sodium diet, so that the sodium which has completely decreased or completely increased can change serum levels. So what you should remember regarding toxicokinetics, not to occur, you should keep on seeing what are the formulations what we are using first. Second, the most important is lithium is neither metabolized nor it is plasma protein bound. It's a free drug. It is getting excreted as such in the urine. And lastly, bioavailability, where there is 100% absorption, and that too rapid absorption. So these are the problems which are met, which can lead on to toxicokinetics, that is the absorption, distribution, metabolism, and excretion. All four are affected here. So you have to be careful whenever we add on lithium. So there are so many problems with lithium. So we have started using sodium valproate, which has got broad spectrum action. It is a sodium channel blocker, T channels, calcium channel blocker, increasing GABA and decreasing glutamate. So these are the actions of sodium valproate, except that it cannot be used in pregnancy and reproductive age, where they want to become pregnant, or in patients with pancreatitis. You have to be very alert for enzyme inhibitors, especially, and hepatotoxicity. Yeah, you can make out with liver function test and get along well, or little bit lower the dose, which can give you better effects. So you have to be careful, or even carbamazepine we can use, or even lamotrigine. So these are the things what we can use very commonly. So for that reason, you have to be very careful when we are starting drugs on bipolar disorders. I think lithium do not have any place unless and until it is very resistant and cost effective. Now, these are the pearls to be taken whenever we think of lithium. When the patient is on hydrochlorothiazide for hypertension, do not use lithium. This is the best way. But if at all you have to use lithium, you change hydrochlorothiazide, put them on either furosemide, torsemide, or any other drug of choice. Next, dehydration increases lithium toxicity. So also along with AC inhibitors and CCBs. So adequate hydration, or you can choose other drugs rather than AC inhibitors or CCBs in case of hypertension with bipolar disorder. Sodium valproate is the drug of choice, but as I told you, you have to look upon for reproductive age, especially in females, alopecia, liver function test, and in pregnancy, especially spina bifida is a major problem. So you have to be careful in using. Otherwise, it's a wonderful drug. It's a broad spectrum drug, and it's a broad spectrum anti-epileptic. I think in one of my classes, I had told you people to have 10 broad spectrum drugs in pharmacology. So one of them being sodium valproate. This has got all the actions, whatever we really require or don't require. It acts by all means, and so this is one of the best drugs where we can use it very commonly, very with no monitoring and other things. We can use it very effectively, and so this is the one what we are using nowadays. Next, Lamotrigine is not effective in acute mania, only for maintenance therapy. So, if the patient comes with urgent or acute bipolar disorder, you have to add either most often sodium valproate or carbon. The others have their own problems. The first is lithium, and the second is sodium valproate in acute cases. And you can, if at all, antipsychotic, if it is, you won't add antipsychotics, is olanzapine, and whereas if it is depression, it is most often citalopram, what we commonly use it. So these are the ones. And carbamazepine is the third line. Why third line? Because of risk of bone marrow suppression, hepatotoxicity, enzyme induction, hyponatremia, and it is not useful in aggressive and non-compliant patients. So both lamotrigine and carbamazepine are most often reserved for these cases, like these cases, and in acute we have got only two choices, that is lithium or sodium valproate. Olanzapine is used in acute mania the best. Why do we use it? Because we can give IM and you can see the onset of action within about 20 minutes, and in patients who have got increased agitation, and also it is very fast acting potential is there. Because of these reasons we use olanzapine rather than other atypical antipsychotic drugs. So what you have to remember, the main about lithium, the first and the foremost is pharmacokinetics, what I told you. Once that pharmacokinetics is brought into your mind, the second thing what you have to think is narrow therapeutic index, because even with minor dose adjustments, if the patient who have forgotten the previous day takes two doses, then it's a big problem because it has got a narrow therapeutic window where it can lead on to toxicities also very quickly rather than underdosing. And also it is primarily renal excreted, so severe toxicity can occur, so you have to be careful, and you should start only after doing renal parameters. And hemodialysis is needed. It has to be commenced to increase the excretion of lithium. Why hemodialysis? Because all its pharmacokinetic features is in favor. It is completely absorbed, then it stays back in the blood. It does not have plasma protein bound. It is not metabolized. So these are the findings, and it is getting excreted unchanged in the urine. So these are the things what is in favor. And so which are the other drugs which are removed by hemodialysis? Name 5 drugs which are removed by hemodialysis. I have given you already 2 examples. One is lithium, one is heparin. The other three, please note down, and this is very important. This is very, very important. Okay, so with this, I think you can find one more point about renal excretion is, see, some of the drugs are excreted only by glomerular filtration rate, like aminoglycosides. Some are excreted by tubular secretion, like these loop diuretics, etc. Some of them are they get tubular reabsorption. So in such cases like barbiturates, so you have to make the urine alkaline because they are all acidic drug, lipid soluble acidic drugs. So they are absorbed very fast. So for that reason, you have to make the urine alkaline. So you should have FAD, forced alkaline diuresis, and if that does not work out, you should use hemodialysis. So we had a patient, who was an epileptic in those days about 20 years ago, who was on phenobarbital. Because of its amnesia, both retrograde and anterograde amnesia, patient forgot taking tablet. He thought he has forgotten taking tablets, so he kept on swallowing and landed up in toxicity. So we sat in the, because that father was a very big person, a press person. So we had to sit at home to see that we have forced alkaline diuresis. With that, phenobarbital came off very nicely. Patient recovered very nicely within about 18 to 24 hours. So these are some of the drugs where we use hemodialysis as the last resort once we cannot use the other drugs, like forced alkaline diuresis or antagonists. So please remember 10 drugs which are removed by hemodialysis. So we'll go to the next problem. These are few things where you have to maintain the renal parameters renal excretion is very important, the kidney function is important. So you have to keep in mind all these will be done when you are sitting in the front of the patient within a minute. So you have to know the route of administration, what happens in pharmacokinetics, that is what the body does to the drug, and then of course what the drug does to the body you have to know, otherwise there is no point taking the drug. And once that is done, you have to know, remember about adverse drug reactions, narrow therapeutic index, window, and also the therapeutic drug monitoring. The clinical therapeutic drug monitoring is drug holiday. Okay, drug holiday, where most often give a single day holiday, like Sunday is holiday, tell them not to take on Sundays. So this will maintain most often the therapeutic levels in the body, and whenever the drug is excreted unchanged in urine. Again, list 5 drugs which are excreted unchanged in urine. One is lithium, second is aminoglycosides. Another 3, I'll leave it to you to do this. These are the questions what you should really remember and by heart, and it should just come out as an emergency. So in all emergencies you act, whereas in chronic you think and you write the prescription. Similarly, drugs which can be removed by hemodialysis, drugs which have got narrow therapeutic window or narrow therapeutic index, drugs which are excreted unchanged in urine. These are the ones what you should be really aware, because today is the today is the era of polypharmacy. Patient will be on so many other drugs, and you being a psychiatrist or just a GP for refilling of prescriptions or whatever it is, you simply go on writing. After 2 weeks or 2 days or even one day, the patient may land up in casualty. Rather than giving him a good quality of life, you will see that he is bankrupted. So these are the problems which are met. So you have to be careful, and so drug history is important, and you are within a minute you have to solve all these pharmacokinetics, pharmacodynamics, routes of administration, including ADR. You have to think, and then your pen should be very fast in writing these things. Remember, but remembering these things, you have to write it. Otherwise, there is no use doing all these things. Okay, we'll go to the next case. If you can see it. Hello? Can you see? I'm not getting the response. Hello? I hope you can see this. We will go to the second discussion. This is also one of the most important one, that is drug monitoring. Okay, so we have to monitor before administering itself, or if we have administered, we have to monitor in various ways. The previous one we saw, we monitored as therapeutic drug monitoring. We took serum levels of lithium and all those things, and we saw that this just floats in the body like whatever and however it wishes. These are the problems which are meant. So you have to monitor in that way to prevent toxicities. For the others, how will you monitor the drug monitoring and see that they don't land up in any sort of toxicity, and it will maintain the usual levels to have a good effect for whatever things you are giving it. So here I have highlighted in red what are the problems. We will see to it that we rush it through. The patient is suffering from atrial fibrillation and glaucoma. Okay, and it is a 72-year-old woman, 72-year-old woman suffering from atrial fibrillation and glaucoma, and the drugs are obviously atrial fibrillation. Apart from beta blockers, you have to take warfarin, that is the drug of choice. But now we have got wonderful drugs for this to prevent this coagulation in case of atrial fibrillation, to prevent all the thrombotic phenomenon, all in all, right from head to toe, you have to prevent. So normally we use warfarin because, again, like lithium, this also has got several problems. Drug interaction here is the main problem. So for that reason, we have come out with novel oral anticoagulants or directly acting oral anticoagulants, where we need not monitor. Bisoprolol, obviously it is a vasodilatory beta blocker with beta 1 active blocking activity and nitric oxide activity, where nitric oxide causes vasodilatation and beta 1 blocking decreases the heart rate, which is very much useful in young hypertensives. And latanoprost is a prostaglandin analog, which we use it as drops in case of chronic simple glaucoma. You see the diagnosis glaucoma is there. So the first drug of choice is latanoprost, but nowadays it is a combination therapy. Wherever it is, we prefer combination therapy and attack in everywhere and everywhere, anywhere and everywhere. So we use latanoprost, timolol, and dorzolamide in combination, especially for chronic simple glaucoma. We do have something known as acute congestive glaucoma, where the pressure increases within 24 hours, whereas in chronic simple glaucoma, first time we see that the what is normal intraocular pressure? It is between 11 to 21, and the person might have some 30 or 40, and that remains even after death. So that's why we use this latanoprost, timolol, and dorzolamide in combination, so that the patient can lead again a good quality of life by seeing the world. And also, she's a return. This is all because the patient will be all alone, and we have to know how to manage this geriatric person. That's the whole issue why we have added 72-year-old woman, then a musician, then independent, not alcoholic, not smoke. All these we have added to show that they are independent but at the same time geriatric. So in that case, how to manage these problems. So we have just again elaborated here, but here you concentrate on atrial fibrillation and glaucoma. The current medications are these are the ones, especially warfarin 3 milligram. OD is most important one. Next, the results. I think all of them are almost near, and it's good. All of them are good except CRP. So what does CRP denote? It suggests lot of higher inflammatory processes, what is going on inside the body. And INR is high. It should be 2 to 3 for warfarin, but it is 8.2. What is the problem if it is so high? There might be toxicity first of all, and also the bleeding thrombosis can occur at any given time. So you have to monitor the warfarin dose also. Now, a brief glimpse about the drugs used in atrial fibrillation as well as glaucoma, so that we will see what best can we do in this sort of patient where there are multiple drugs. So for atrial fibrillation, normally we give beta blockers. The order of choices: beta blockers, then calcium channel blockers, then evobradine funny channel current openers, then cardiac glycosides. Lastly, why is it so? I think you have to answer, because we have already dealt several times with regard to so many cases, like, for example, CCF, arrhythmias. These are the only two indications for digoxin. We have told you in detail about mechanism of action, and only one electrolyte is important for it to cause arrhythmias as well as to treat arrhythmias. So, because of that, this has gone to the last, because though it is a beautiful drug, the three most important points why digoxin has gone to the last place is it should be monitored. One, second, narrow therapeutic index. Okay, and third, it can cause arrhythmias itself. So these are the problems, and so we want to put that in the last. So these are the drugs which we have, I think we have dealt already. All these cardioselective beta blockers and vasodilatory beta blockers, they block beta 1 receptors and slows the AV conduction, so the ventricle is spared. And these are the first drug of choice because they are quite safe, except you should not use when the heart rate is below 60, that is bradycardia. Diltiazem is the drug of choice because it is a rate controlled one, and verapamil and beta blocker cannot be used alone. They will cause heart block. So for that reason, you have to avoid the heart failure, especially with reduced ejection fraction. And mainly they are all L-type calcium channel blockers in the heart, where it blocks and slows the conduction. Digoxin, as I told you, it causes arrhythmias and it is used in arrhythmias. It is used in arrhythmias because it increases the vagal tone, so it is vagomimetic, decreases the heart rate, decreases the conduction. And it causes arrhythmias again by increasing calcium because of sodium potassium ATPase pump. Calcium is increased inside the cell as well as in the sarcoplasmic reticulum. It comes out, and again there is increase in calcium. So because of this, there is atrial arrhythmias. So you have to, it is the same this one, and normally we use FAB antibodies here, and if at all it will cause arrhythmias, you have to again bring down the rate. by again using these sorts of drugs, but most often we use Fab antibodies. Okay, ivabradine is the indication is only when these beta blockers do not bring down the heart rate below 100. If they don't bring down the heart rate below 100, then you have to have ivabradine. So that's the main area where we use ivabradine, and it's also a funny channel modulator. Funny channel modulator. So you have to know the heart rate before you restart on ivabradine. Now, the few of the glimpse of drugs used in glaucoma, mainly chronic simple glaucoma. The first drug of choice is prostaglandin. Here it is mainly PGF2 alpha. It is mainly PGF2 alpha. So it increases mainly the uveosacral outflow. It is nothing to do with iridocorneal angle. So we are sparing that, and it is increasing uveosacral outflow. The main drugs are lactoprast, travoprost, and bimetoprost, and they have this mydriasis and also iris darkening and eyelash growth. So these were drugs of choice to be used even for this fashion shows and all, even in these artists where they want a mydriatic eye with a lot of colorful things. In such cases also we use it, least realizing their side effects. Next, beta blockers, mainly we use timolol, which can be given as topical, reduces aqueous humor production by the ciliary body by acting on beta 2, beta 1 and beta 2 receptors. So we use mainly timolol, bitoxolol and levobrinolol. This bitoxolol is also mainly beta 2, where we do not have, and so this we do not use very commonly. We use timolol very commonly, but timolol, just by putting as drops, it can cause asthma. It can cause asthma. So for in such patients, you use bitoxolol and avoid these timolol-like drugs, because just by absorption, if the patient is prone for asthma, it can cause very severe bronchospasm. Very severe bronchospasm. And remember that the person is also atrial fibrillated, so you have to think twice before adding timolol, though this is the first drug of choice in any case of chronic simple glaucoma in combination therapy. Carbonic anhydrase inhibitors, the topical ones are used in chronic simple, whereas acetazolamide is only oral or IV, which is used in acute congestive glaucoma. They are all known as topical carbonic anhydrase inhibitors, and acetazolamide is just a carbonic anhydrase inhibitor where we can give both parenterally and orally. These are the latest new drugs, and some of them are not used also. Alpha adrenergic agonist, brimonidine, aproclonidine, again one of the drugs of choice along with latanoprost and timolol. And here it has got dual action. Also, it decreases aqueous humor production, so the quantity is reduced and also increases the flow. So both the ways it is targeted. So it is very good in these cases. And cholinergic, we don't use it nowadays. We use mainly pilocarpine ocusets, a newer transdermal drug delivery system like ocusets, where we can just apply it below the lower eyelid, and it delivers the drugs for almost 1 week. So most often we use it in acute congestive glaucoma, and chronic we use it as ocusets. We do not use because of its spasm, ciliary spasm. That's the main problem, and also blurred vision is a problem. Because of these, we do not use. Carbachol is non-specific now; it is not even available. But to remember, you have to have. The latest ones are Rho kinase inhibitors. Mainly, they increase like other drugs, tablets like measure outflow. The drug is netastrudil. Netastrudil. These are the ones which we can use it only as an adjuvant therapy, but we have to be careful when we use it as main therapy, which to use and which not to use. As I said you earlier, combination of two drugs will have synergistic effect, increases the efficacy, decreases the cost, and patient compliance is also improved. That's why we use this fixed dose combination or combination therapy, timolol, dorzolamide, brimonidine. Or we can use two drugs, timolol, dorzolamide, or brimonidine and timolol, which will increase not only the aqueous humor production is decreased, increases the uveosacral outflow, and on the long run, it also will increase the flow through the iridocorneal angle. These are the good effects what we have in combination. So we have started using combination therapy. Now, with this preamble, and one more preamble is anticoagulant drugs. Everywhere and everywhere we were using warfarin because that was the drug. Now we have got newer drugs, that is directly acting oral anticoagulants. I think we have tell 2 or 3 times. That's why I thought I'll just tell you these as a brushing point so that you can remember. Or if you know very well, I think you can talk and I can stop speaking also. So this warfarin was the drug which was administered, but nowadays we have got directly acting oral anticoagulants, that is rivaroxaban, dabigatran, and and apixaban. Apixaban, you have to be careful during renal insufficiency. Otherwise, the other two are wonderful drugs where we need not even monitor this INR ratio, where you have to look upon with warfarin, especially for drug interactions, maintaining INR ratio. Okay, and it is plasma protein bound. Drug interaction can take place even in the blood, in the distribution level itself. So many problems are there. So for that reason, we have resorted to direct thrombin inhibitors, oral direct thrombin inhibitors, that is rivaroxaban, apixaban, as well as rivaroxaban, apixaban, and dabigatran. So these are. So now, how to solve this problem? INR is very high. Okay, we saw in the previous slide, no? INR was high. Okay, and CRP was also high. So for that, how can we solve the problem? What all permutation can we take? What is the important next step to monitor the drug administration? So can we withhold the next dose of warfarin and recheck the INR on the following day? Will it be good? Will it be good? We don't know. Administer phytomenindone 2 milligram IV and recheck INR after 4 to 6 hours. Phytomenindone is vitamin K, which is an antagonist to warfarin. Why? Because warfarin by its gamma decarboxylase reaction, the gamma carboxylase reaction, the factors 2, 7, 9, 10, which is present in the plasma, is inhibited by warfarin. So, which are all vitamin K dependent. So, if you administer vitamin K, those are recovered, and so you can really do it. But vitamin K orally takes 24 hours to act, completely act, whereas when you give IV, it takes about 4 to 6 hours to act. Next, administer phytomenindone 5 milligrams and recheck INR after 4 to 6 hours. Next, administer phytomenindole per orally and recheck the INR. Lastly, administer fresh frozen plasma and recheck INR after 4 to 6 hours. So, which can be the real one, what we can really think of in this case? Again, 1 minute job, but here I am telling you for 10 minutes. Okay, so what are the different steps which are this one, and so what's the reasons for this? So administer phytomenindone 5 milligrams IV. Why phytomenindone? Vitamin K antagonist. Why 5 milligrams? That's the usual dose. Why IV? It should act faster. Even if it acts faster, it will act by about 4 to 6 hours. So that is the reason why we want to use phytomenindone only by IV, not by decreasing the dose 2 milligrams or even per orally. So IV, it is 4 to 6 hours, per orally 24 hours. Okay, so these are the problems what we have. So we are administering this IV, which is fast and effective way to lower the INR immediately. Then recheck. Why do you want to recheck? To monitor the effective reversal. And then you want to withhold warfarin. So to prevent further INR, you give a drug holiday of 1 or 2 days, looking at the amount or the level of the INR. No fresh frozen plasma because this is mild to moderate. When do you use fresh frozen plasma? In an acute setting. In an acute setting, and also when there is hypovolemia. Both of them, and there is a lot of bleeding. So in such cases, we use fresh frozen plasma. Fresh frozen plasma contains factors as such. Okay, so they need not depend on the liver to synthesize the factors. So for that reason, we are giving fresh frozen plasma. Nowadays, of late, apart from fresh frozen plasma, we have got something known as dried prothrombin complex, or otherwise known as 4-factor prothrombin complex concentrate. So this is the one what we have normally. 4-FPCC. 4-FPCC is the one which is available, and this will reverse the coagulopathy within 15 to 30 minutes. So you can gauge, no? So 15 to 30 minutes in this 4-factor prothrombin complex. fresh frozen plasma at least for about 1 hour, because it contains plasma contains these factors, but it should act. So it takes little more time. Then withhold warfarin, it can be useful. Okay, if you administer orally 24 hours, when you administer IM, it is about again 4 to 6 hours. If you administer IV, it will be almost immediate. So for that, we are using IV. And when you use this, no doubt they will reverse the coagulopathy within 15 to 30 minutes and with less volume compared to plasma. If you use plasma, there may be volume overload. So if you're using direct prothrombin, see previously we had only blood. Okay, blood and frozen ones. These were the things. Now then they separated plasma from the red blood cells and other things. Then after that they separated, even in that plasma, they separated different factors. Whenever required, that can be given directly, so that we are not wasting time and we are also not making fluid overload. So for that reason, these sorts of four-factor prothrombin complex concentrate is mainly used to reverse the coagulopathy within the 50. It reverses coagulopathy within 15 to 30 minutes and less volume compared to plasma, because plasma will have a lot of liquid which can increase volume overload, which is normally decreased when we use this prothrombin complex, but very, very costly. Okay, so these are few things what you have to remember in this case for case of drug monitoring. So once it is between 2 to 3, once it is between 2 to 3, you are safe. So for that, how will you prevent it? You should tell them when you take warfarin, you have to take it only at 6 o'clock. Never change it. Don't change the dose. Even if you want to take paracetamol, you ask us and only then take. Don't take any other extra. Don't take grapefruit juice because it is enzyme inhibitor. So these are the few things what you have to force them so that they learn and be independent to themselves for whatever time God has given to. Okay, I hope this was quite useful to all of you. Thank you for your patient listening.